many people will take antidepressants and not have problems stopping them. But what are the chances for those people who take antidepressants and find that they can't stop them? What is the chance of them being believed? My temperament changed. I fell out with the neighbours. I did erratic things like throw things in the garden and stuff like that. I was blaming my wife for things that she hadn't done. I mean, I wasn't delusional, but I wasn't Peter. Knowing what I do now, there was no way I would have taken an antidepressant. I'd have sought maybe some other short-term measures, physical measures to support me, and relied on the love and support of my friends, who I have many, and my family.
Hello and welcome. This is ICI Stories, and I'm Cooper Davis here at Inner Compass Initiative. I am here joined today with Peter Gordon. Why don't you give us a little bit of your kind of current, who you are today, and then we'll jump back and figure out how we got here.
I retired 4 years ago. I worked as an NHS psychiatrist in Scotland for over 25 years. I retired at the age of 52, so I retired early, and I have my own experience of long and protracted experience of taking a prescribed antidepressant, which I was initially prescribed for anxiety a long, long time ago. I am so happy to be called a retired doctor, but these days I'm a gardener.
NHS, just a quick reminder, is the National Health Service, which is what in the United States people would describe as socialized medicine, more or less, although people who actually receive NHS services might quibble with that definition. But essentially, there's a slightly different set of incentives and dynamics with medical care in general and psychiatry in particular in the UK, because of the role of the NHS and the amount of taxpayer money that goes into it, and it's the responsibility that the NHS has been charged with. So just that's a little note. We can't, as much as we might like to, we can't map the US experience of psychiatry as a practice onto the UK experience exactly.
Yeah, I think that's right.
And so I guess getting into that initial you starting treatment on that SSRI for anxiety, do you want to talk a little bit about what were you calling that before you thought of it as anxiety?
I think people outside me would say and would confirm this. I'm quite sensitive. I'm quite gentle. I've got a good sense of humor, but I can be quite serious too. I'm quite principled. But as a young man, I was really quite. Most people will identify with this. I think I was quite sensitive. I was quite shy. I wasn't bold. I wasn't an extrovert. And my family backdrop was difficult. My childhood was difficult without any major traumas, but it was difficult. And I'm not going to go into that here. So I married Shan. My life was going well. And then our first baby was born. And there was nothing to do with our first baby, Andrew, who's now a grown man. But his infant feeding was very difficult. So nights were extremely disturbed for both of us. And at the same time as this, I was training in psychiatry and doing my membership exams, which are quite a lot of work. So I was stressed and I was sleep deprived. So I went to my local doctor, the GP, and she said, "Oh, well, there's this new medicine that's just been licensed for social anxiety, and I think you should try it." And being in psychiatry myself, I was then receiving training like this, which was I was banging what was called I don't think you had it in America, but in the UK it was called the Defeat Depression Campaign. And it was a 5-year campaign from 1993 to 1998 that was sponsored primarily, not only by, but primarily by the pharmaceutical industry. And the Royal Colleges in the UK, the General Practitioners College and the Psychiatrist College backed this campaign. And this campaign was to educate both potential patients, the public, and doctors alike, that there's no shame in taking an antidepressant, that they can be used for other things other than just depression, such as anxiety, menstrual problems, etc., etc. So it was a widely based campaign. So this is part of my training. So I thought, what can the harm be for me trying an antidepressant for my sleep and anxiety? And I'm going to stop there, but 30 years on, I wish I'd known different.
Which SSRI was it that you started on?
Yeah, I think it's different names in the USA, but it's probably Paxil with you. Is the chemical name is Proxetine. In the UK, it's called Thiroxat. And the advert for throughout the period of the Defeat Depression campaign afterwards, which has always struck me as with great irony, the advert that the pharmaceutical company used was says, this drug has a powerful embrace. They were saying the powerful embrace is a positive thing because it makes you better. But by God, this drug has had a powerful embrace in me, though I'm smiling and happy just now. I've learned to live with this drug and its many consequences, and maybe come to later at some points where it's really been awful. But over these 30 years that I've been on this drug, I've tried a number of times, and particularly I was one of the first really to try and get off this drug in Scotland, realizing that I had a problem with dependence on it and withdrawal symptoms. But just to let you know, I'm still taking this drug now, and I've decided to still take it. And people can argue whether this is right or wrong. I've heard some people say, "Oh, Peter, you lack balls because you've not come off this drug." I don't want this drug. It's affecting my life, and I'm living with it. I'm getting older now, but all the side effects, the small side effects that they say, they're catching up with me.
One thing that we feel strongly about here at Inner Compass Initiative as an organization, and our team, and it bears repeating here, that there is often a presumption that that sort of our goal. We've been accused of being anti-drug. We are not anti-drug. We are pro-informed consent. And so what you described, Peter, is an incredibly common experience where you are now being able to make a fully informed choice. Maybe in the past you were not, but now you have access to all the information. You know the cost and benefit of staying on it. You know the cost and benefit of trying to struggle to come off of it. You know what it does and does not do. And so as far as the organization that is hosting this conversation is concerned, that's where we want people to get to. Ideally, it happens earlier, right? Ideally, it happens before that first meeting.
I think the slightly different thing from me, though I'm not alone, is that not only I've not been a patient for a long time, though I'm on a prescribed medication, but I've been a patient and a psychiatrist. And I think one thing that's different with me is I've got this longitudinal history to see what has happened in the narrative, particularly by antidepressants, from 30 years ago to today. And that narrative is, I think, one that humankind needs to listen to so that we don't, hopefully, repeat the mistakes again. I'm not anti-psychiatry, though I'm accused of it all the time. All I'm wanting to do is improve people's lives. If medications help them, that's fine. I don't have an issue with this, but we need to keep our ears open, our eyes wide. Otherwise, we won't learn. But it's revealing that psychiatrists themselves, in this case, very senior UK psychiatrists, can be as stigmatizing as anybody else, if not worse.
So I want to make sure I have this right. So you're experiencing, as a sensitive man, a difficult time in life, a disruptive time in life. I have a new set of responsibilities. The focus of my life has shifted. And so you're entering a sort of different life phase and a different, almost like you're now have to become a new persona. And you're experiencing that with a lack of what feels really necessary. You need more sleep. You need more to feel more settled. You need to feel like your decisions are coming from a place of groundedness. So family doctor suggests off-label, what we call off-label prescription, because it's for depression, it's not for anxiety and sleep, right?
It was primarily sleep disturbance, and at the same time as studying for professional exams.
You go with a problem in mind. That problem is offered some definition. Let's call this anxiety. And then here's this solution that's available to that anxiety is this drug. And so I'm wondering if at any point did your conception of your problem shift once you started engaging in psych treatment, even if it was through your GP and you weren't getting psychotherapy or anything or whatever it is that prescribing psychiatrists do? Did your sense of what you needed change before that appointment to after?
Yeah, it's a really good question, Cooper, and it's not entirely straightforward to answer, but I think I showed this book briefly. You can't see it, but if you read along the top, it says, Down with Gloom, How to Defeat Depression. I used to hand this book out to patients because at this time that I was having anxiety, I was at the early stages of training in psychiatry. So this is 93 to 98, really. And at that stage, I was still training in psychiatry. And every teaching we were taught about one important word was often missed out here, the chemical imbalance theory. And the important word that was missed out, or we kind of forgot, was theory. And so, though there's a number of very senior psychiatrists today that say that the chemical imbalance theory was never taught to psychiatry, particularly a professor in America called Ronald Pies, what a load of baloney. I can't speak for America. I can speak for my training because I was training at the time. We talked about the chemical balance inside out and how that relates to me as I thought, because that's what I told my patients. You've got a chemical imbalance and you shouldn't feel any shame in taking an antidepressant, whether it's for depression or anxiety or some other problem. This is fixing a deficiency of a neurotransmitter released in your brain. Don't feel any shame about it. So that was my mindset when I went to my GP. So I thought there's no harm in this. But one of the big key messages it gave to both patients and doctors like myself were that there would be, and I can quote, I think pretty accurately, that we should dispel the idea that there will be any difficulty in stopping these medications. That was the key message sent out. And I, like all the other people, believed that. I took it. I thought that this is a factual thing. This is evidence-based medicine, which we were beginning to learn about then.
So do no harm is this driving ethos. And so the way do no harm can sometimes be hijacked is if you say that, look, whatever harms people are concerned about are less than the harm of not taking treatment X, that's a claim that is very difficult to verify, but it has a really high emotional resonance. So you see it in all kinds of different places. But with antidepressants, a good doctor, an intelligent doctor, or a good guidance counselor, or a good social worker, or a good psychotherapist, or any of the people who we tend to turn to in the system. These are people who are often driven by their compassion and care, and they want people to be okay and taken care of. And so you have to be careful about telling people the truth because they might die if you do that. So that last part of that is a bit of a jump, right? There's probably a lot of room between, people dying and people being given like the full picture on what the evidence does and does not show with these treatments. I think there's a lot of room in there, but for some reason, the discourse even today still tends to be uninterested in looking at all the space in between those 2 points.
Exactly. I'm so passionate about this too. I'm so passionate. It's not as if everything is all good and all bad. There's the wide range in between. And it doesn't help any of us if the debate becomes totally polarized one way or t'other. And it's just exactly what you said earlier on, Cooper. This is about having discussions with a wide range of people so that decision-making can be as informed as possible. When we're suffering, all of us, and we're all involved in this, are often looking for quick fixes because we're suffering. But the trouble with this is that if you've got a simple answer to a complicated thing, the simple answer can turn out to have some issues, and I'll stop there.
Because you're a psychiatrist in training, you already have this, you're going into this with an assessment that like, yeah, my brain is just having a tough time with this for whatever reason. There's really no downside to going on this treatment. I see a clear, like, the problem is a lock. The pill is very likely to be the key to that lock. And I need to sort of get on with my life. And so I think what a lot of people find when they look back at their story, things change between before you went on the drug and after you went on the drug. But it wasn't just the drug that was changing. It was the circumstances of your life were changing in profound ways. And in hindsight, being able to tease out how much of this was the drug, how much of this was just like this whole new set of responsibilities that I had, right? And so tell me subjectively, acutely, what is your experience when you start to notice a difference? What is that like? And then sort of in hindsight, less acutely, but more ambiently, what was your experience?
I didn't have a terrible response to taking Seroxat the very first time I started it. I didn't know, from my memory, I didn't notice a big difference in my sleep or my anxiety. And I've asked my wife about this, and she says no. But I kept taking it, and so it didn't make a big difference. It didn't make things awful. Just didn't make a big difference. And probably it's hard to know exactly, but I would estimate it was maybe about 3 months into taking this medication, I just stopped it because I thought it's not making a big difference. Nothing happened. And what I can remember vividly is what happened when I stopped it. I'd been off it probably for about 36 hours, and I was out in the garden, and I got this buzzing. People have heard this before, but I got this buzzing in my ears, and it wouldn't go away. And then this profound headache, and I was sweating. And I came into the kitchen, and I said to Shan, who's a GP then too, I said, do you think these symptoms I'm having, do you think these could be related to the fact that I've stopped taking my Seroxat? And she said, no, I don't think so. No, I don't think so. I think it's something else. Anyway, so I took the Seroxat again, didn't think much more of it. And then a few months later, I can't remember exactly, I tried to stop it again and had exactly the same. And it was at that stage, there was a light bulb moment. I thought, there is something with this drug. When I stop it, and I've not had it for at least 36, 40 hours, I get these symptoms, and I don't know what they are. So what I went to that stage is, because I had a good relationship with my colleagues. I was training in psychiatry, and I went to a consultant psychiatrist who I still keep in touch with. He's a lovely guy, brilliant doctor, absolutely brilliant doctor. And I said to him, Phil, when I stop these drugs, I feel really bad. I get these symptoms. Do you think it could be related to the antidepressant I'm taking, Seroxat? Oh, no. There's no evidence of that. Peter, I don't think that's the case. And then that started a pattern from then on that I realised, and even just about all my colleagues in psychiatry were lovely people, well-intentioned. But when I mentioned this subject, and I said, look, I think there's more. In my case, I said, I'm not saying this may be true for all people, but in my case, I don't seem to be able to stop this drug without feeling hellish, both physically and mentally. I think I got much more anxious than I'd been when I'd first presented with my symptoms. And they said, no, Peter, this is you. They said it in nice language, but they said, this is you. This is relapse. And I would say to them, how could I have relapsed to this? Because these weren't the symptoms that I had when I first took this antidepressant. I said, these symptoms are far worse. And I said, they go away when I take the medication again. But my universal experience was that good and kind people didn't believe me. And the narrative that they were following, as I had done, was this safe and effective, that these drugs do not cause withdrawal problems. You can't become dependent on them. They are not difficult to stop. I guess what I want to get across to you is, as a psychiatrist, if I felt so effing isolated, and I did, I felt unbelieved. I was unbelieved. But if I felt that, what are the chances for those people? And many people will take antidepressants and not have problems stopping them. But what are the chances for those people who take antidepressants and find that they can't stop them? What is the chance of them being believed? it was a very early learning signal about how stigma is not so simple. The fact that you're a psychiatrist, that you are combating stigma, or that you have some differential, better approach to it. It's all about narrative. It's about whose narrative is that prevails. But I think what we all have to do, all of us, is do our best to believe other people's experiences and try and collate them to work out what's the best picture to help people be informed about medications. Because you can't rely on 6 to 12-week studies based by the pharmaceutical industry, which I don't hate. They're just doing their job. But you cannot rely on those studies to inform widely based prescribing beyond that period of time.
Did your assessment of what the drug was doing for you or doing to you, how did that change and solidify over time? And was there ultimately a kind of crescendo, or was there a boiling point that was reached?
So we're talking about here 1993, and I was 26 years old, a newly married man. My wife and I had our son, and it was a successful birth. And I continued my Seroxat through 94, probably through 93 into 94. I noticed I was getting side effects. And these, they were not major things. There were things like I couldn't urinate so well. I found it was harder to pee. I sweated a lot, and I still do sweat a lot. And people say it's a side effect, but it can be very embarrassing when you're sweating buckets. And I noticed that when this was a direct association with the antidepressant. There was no two doubts about it, because I didn't have these things before. And I also, a more difficult subject, had difficult sexual problems, delayed ejaculation, basically. And I was a young man. I'm old now, and some of these symptoms have got worse. And because of that, I'm not going to get technical, but the anticholinergic properties of antidepressants, they can often cause symptoms like this. So those symptoms were sufficient for me to think, I don't want to be on this drug longer than I need to be. So I tried stopping it. And then, as you've heard, I couldn't stop it straight away without these side effects. So I said to Shan, what can I do? And she said, I'll get you a pill cutter. You've got to remember, this is probably a long time before people were really talking about withdrawal of antidepressants. And none of my colleagues would have agreed with me. So I didn't tell any of them, just Shan. So I cut my pills in half and then a quarter, and I tried that. I still got the withdrawal symptoms, and I felt really crap. Both physically, I felt like flu. I had this pain in my head, these buzzings. I woke up at night with vivid dreams, rapid wakening. I felt awful, and I was still trying to do my work at the same time. So Shan said, I tell you what, she says, I think you could probably get a liquid preparation. This is, to my best of my knowledge, this is way before anybody else in Scotland had tried this. And she says, I'll get you a micropipette, and you can reduce it very gradually. I tried doing that, and I did it. I can't remember exactly, because this is a long time ago, but I probably tried it over 3 months, and I still felt hellish, so I just went back to the higher dose. Then I gave it a few months and said, right, I'm going to really try this time, but I'm going to do it much slower. I said, there's nobody I can go to for advice, The internet was hardly available then. Well, it wasn't. I said, I'm just going to do it my own way. I'm not going to tell anybody about it, but I'm going to reduce it as gradually as I can by liquid preparation, this micropipette. And I did that gradual reduction over a year, at least a year. Then probably within a couple of weeks of finally getting off the last smallest amount, I became different. I became restless. My nature is I'm quite sensitive, but I became irritable. My temperament changed. I fell out with the neighbours. I did erratic things like throw things in the garden and stuff like that. I was blaming my wife for things that she hadn't done. I mean, I wasn't delusional, but I wasn't Peter. So I thought that was the mental side, and I felt agitated, restless. I wasn't sleeping. I was sweaty. And then I realized my mood was going low, which had never happened to me before. I may be anxious, and I may be a sort of bit of a negative thinker, but I'd never had a severe depression before. But I became really quite morbid, and I thought, particularly my morbid thinking was that I was doing harm to my children, my wee children. And it was very distressing. And so to cut a long story short, then that's in 2005, I had a horrible year. And I can tell you about that if you're interested. I always find this bit the hardest bit of my story to share.
If you want to go there, we at Inner Compass, and I personally am a connoisseur of people's most horrible years. I think if you're willing to share with this audience, we would love to hear it. And I think in general, everybody needs to talk more often about their darkest days. Probably, right?
I'm quite happy to share. I've shared this before, as maybe I have had other interviews, and that though I don't find it easy, it's just easier with time passing. And also, my children are now successful young adults themselves. They're aware of this story, and fortunately, I like to think, although I still feel bad about this, I've always worried about how much of my story with Seroxat has affected them. I don't think it has affected them too much. They were quite wee children at the time. You know, in 2005, my son was 7, 8, and my daughter 4 or 5. So they don't remember too much, but they will remember some, and that'll just be a constant regret. I was admitted to a psychiatric hospital in early 2005, a private hospital, because of my suicidality. And while I was there, I was really driven. I was very distressed. And I never had this before. It was, I don't want to use hyperbole, but it was way more severe than my presenting symptoms for Seroxat. And there's no family history of major mental illness. There was no answer to this. I was given antipsychotics as well as my antidepressants. The antipsychotics were supposed to augment the antidepressants because the diagnosis I presume I was given was treatment-resistant depression. And it just all got so bad. And at one point, I made a very real effort to end my life and had a steel curtain rail not broken in the hospital. I wouldn't be here today. And I'm not going to say much more than this, but then after that, I was admitted, I discharged myself from hospital. I went to my sister, and she took me to another hospital, an NHS hospital, in fact, the one that I went on to work in, where I remained for about 3 months. And I agreed to take ECT treatment, electric convulsive treatment, because nothing else was working. So I had a course of ECT, I think 8 treatments. For me, I don't want to get into the ECT debate. I still have prescribed ECT, and I have given ECT to patients. My view is it shouldn't be banned, but I'm just going to keep this very simple. It shouldn't be banned, but it needs to be an absolute last resort. I've got to use my words carefully because ECT has saved people's lives, and I am aware of that, even though it was just like knocked me out. I couldn't think. And my wife would come in the next day, and I've still got my diary from the time. She said, "I'm going to give you a diary, Peter, because you don't remember one thing you say after another." From the period that I got ECT for a period of probably 12 months afterwards, I don't remember my children from that period of time, and that makes me feel sad. It's a very strange experience. You look at these photographs, and of my children, my beautiful children, and I don't remember it at all. So the reason I'm laboring on that is to say, look, my experience of Seroxat withdrawal has been significant, very life-changing. This may not happen to everybody, and it doesn't. I've seen many people able to get off antidepressants. Some people can stop them, no problem at all. But there's a significant number of people like myself who can't. And time is now showing there was about 1 in 40 or 1 in 50 people taking an antidepressant. Then the Defeat Depression campaign, and it gradually went up. So it went 1 in 20. And when I started campaigning, it was about 1 in 20. Went to 1 in 10, 1 in 8, 1 in 9, 1 in 8, 1 in 7, 1 in 5, and it's now 1 in 4. You've got to ask the question, why are so many people taking antidepressants? And it's one of the reasons for this is that they are actually, for a significant number of people, very difficult to stop and cause great distress. And my last thing I'm going to say on this is that what the psychiatric profession have said in response to this is that all these people, the kind of argument is that all these people, this is relapse of their illness. It's not withdrawal. I would question how much professionals are mistaking withdrawal as relapse. I mean, it would be absurd, I would say. In fact, we've never known it. For, say, 1 in 4 of the population to have major depressive disorder that relapses and that they need treatment for that, even a percentage of that, it would be absurd. That's over-medicalization, juggernaut over-medicalization, and it's not helping anybody. Antidepressants, in my view, have a role, but will massively prescribed for long periods of time? No. And I think they have significantly more harms than the safe and effective mantra that we were all educated to prescribe them.
What I am interested in, though, is who is incentivized to know more? right? Who is incentivized and to what degree to seek out that information of how much of this is withdrawal and how much of this is relapse? Because I know who's incentivized to avoid a deep inquiry into that question. Lots of entities are. And I don't think those entities are necessarily nefarious or good or bad or whatever. So I don't think that there's some evil pharmaceutical cabal or anything like that. And I know you don't see it that black and white either, but I do think a lot about incentives in that.
If you're an academic psychiatrist or scientist or researcher and your career has been based on this, it's only understandable that you're going to be defensive. I don't see these people as bad people. I don't. I just think that we're all of us are vulnerable to biases, and particularly when you're motivated in an area. And so academia is a big part of this, certainly in the UK academic psychiatrists in this area. I wouldn't generalize it to all of them, but I would say the ones involved in antidepressants who've had a career in this area come across, and indeed the Royal College of Psychiatrists, increasingly are coming across as defensive. And I don't think it's because they're bad. My experience with psychiatrists were generally good people, well motivated. I think there's a lot to lose here. There's the reputational loss as well, trust in the profession.
Imagine you, Peter, today are suddenly, you're a pharmaceutical executive. Okay. Would you, you're in a boardroom with other pharmaceutical executives, and they're saying, guys, guess what? I think we need to come up with some ideas for the Scottish government on how they're going to use the apparatus of government to help us sell more antidepressants. We're thinking defeat depression might be a good tagline. Okay, you're there, and your job with all of your experiences that you've had so far, your job is to respond to, Peter, what do you think? Defeat depression. How do you like that as a tagline? What would your response be?
In that position, it's a good question. If you're in a business and you want to be your business successful, what do? You want to have a simple message. You want to brand it. You want to associate it with a very easy phrase such as powerful embrace or safe and effective. Whereas the safe and effective is probably true based on the evidence, but the evidence is only 6 weeks. So you just don't tell people that actually this evidence is only 6 weeks. And actually most of that evidence you're never going to be able to see because it's hidden in the bottom drawer. And so as an executive, let's just tell the positive messages. Don't tell the negative messages. And as for all the in between, which is life, let's cut that out. Simple message. Let's go for this market. This is a market business. To get our business booming, we need to market our drug. And what I would say in my position as Peter, a faulty, older man now, as human beings, all of us, whether we're chief executives, prime ministers, senior civil servants, we need to stick to our values, human values. And that may sound very twee, but it's true. Values matter. Values are far more important than money. But money is what makes the world go round. And we can't live in a naive world where we think we can completely separate from money, because that's just never going to happen. But if we stick to our values while still doing our business, then I think we'll do a better job. And I think scientists, there's one other word that needs to come in here, is humility. Because what's often come along with this evidence-based, I passionately support evidence-based medicine. I would say it's better to be evidence-informed medicine, because evidence-based suggests that you've based it in a very wide range. But in fact, as we've seen with antidepressants and other medications, statins and all those things, actually the base was very narrow before it became prescribed in a mass way. So I'm passionate about evidence, but we need to still have some philosophy, because evidence, there's so many aspects that are wider than evidence, like passing time. It's very convenient for us human beings just to say, oh yes, that's evidence, but it's finite for a short period of time to a small number of people. So we need to listen to each other. We need to respect passing time. We need to be more humble and show some humility. Evidence isn't the only answer, because if we just go down that route, you'll get this great polarization that we're seeing across Western world, really, where I'm right, you're wrong. No, no, no. There's middle ground here. We need to learn from each
Mm.
other.
And I'll just reflect back that I think to me what bothers me about the defeat depression more than anything else is the lack of humility, because it's operating from the assumption that this is something that should be defeated, right? The when I work with young men who have been diagnosed ADHD, who are either deciding to try, getting off the stimulants, or want to be on the stimulants differently, or don't want to go on at all in the first place. And, one framing that I use is, well, if you want to buy into this diagnostic framework, that's fine. That can be useful. So if we're doing that, though, the goal here isn't to overcome your ADHD. The goal is to get better at being ADHD, right? The goal with depression is the same. The goal is not to defeat it. That's a dubious goal.
You're right. I'm very careful not to use words like defeat or military metaphors. And I try my best anyway.
We're going to provide some links to Peter's stuff in our show notes here. And I advise everybody watching this to go check out his website, which is just will spoil you with the riches you will find there, and is worthy of taking some time with it. So my final question for you is this, Peter: what can psychiatry learn from landscape architecture?
That's a great question. I love it. Thanks, Cooper, for asking that one. Well, let's start at the big level. What we're all trying to seek, what we're all looking for, and that in the widest scale is a healing landscape. Let nature in. Let nature in. Let's understand that weeds are just weeds because people have named them weeds. They're just actually flowers. I think psychiatry is needed, and there's some people that go through some very severe episodes of distress, illness, whatever name you want to give it. Be wary of the names that we give to disorders. But if you're distressed, psychiatry is generally a good thing. But do your best to, just as you've described earlier, Cooper, is to try and learn from the experience of other people who have maybe been in a similar situation to you, and to think maybe there's other ways. And be wary of getting involved in interventions of any sort that are based on evidence that is short-term, because the short-term evidence might show benefits and harms, but it's not evidence for longer-term use. And I think all of us need to be wary of, which nature tells us, the healing landscape tells us, that cycles of life move on. And we can have, like I did, have very bad times, at a difficult juncture in my life. And I did need support. If I went back now, I think knowing what I do now, there was no way I would have taken an antidepressant. I'd have sought maybe some other short-term measures, physical measures to support me, and relied on the love and support of my friends, who I have many, and my family. So there's a lot to be learned from landscape architecture and indeed the medical humanities. They're not both here. People, I was generally liked as a doctor, and people were sad when I retired early, including my colleagues. Of course, there was one or two people I didn't get on with, and they didn't go on with me, but by and large, it was fine. But what my universe of experience is that people would often my colleagues would say, "Oh, that's just Peter. He's interested in medical humanities. He's an artist. He's sensitive. It's all that fluffy stuff." And I would reply to them, I said, "No, I'm just Peter. I just happen to have done those things. I'm not saying I have all the answers, but I said, please don't dismiss these fluffy things as not being able to help you in your life and help you through difficult periods of time. Maybe in addition to psychiatry, or psychiatry could be a small part, but psychiatry shouldn't be for a healthy well-being in the world. We should, 1 in 4 of us, or whatever the figure might be, it's a massive number these days, shouldn't be dependent on psychiatry. We shouldn't have a mental health label. Let's try and, while we're here on this planet, do more good for ourselves and our fellow inhabitants, and not just human beings in this world."
Mm-hmm. That's beautiful. Thank you for that, Peter. And what strikes me, and what I'm taking away from our conversation today, and I hope others I'm sure they are hearing this as well. You've mentioned a couple times this, this orientation towards the passage of time. And I think that as a gardener, anyone who has planted a garden or raised children or just, you make some decisions in a moment, and then those decisions play out over time. And there's some stuff that you can know. There's some stuff that just is not knowable, right? There's stuff that's not knowable. This is where humility comes in. But to your last point, in the absence of perfect information, right? The absence of truly being able to know everything about how everything might go, whether you're planting a garden or treating a patient or making your own decisions about what diagnostic framework to internalize or what drug treatment to start with. And in the absence of perfect information, we must instead rely on something else. And if you're dealing with imperfect information, I think that the best guide for navigating decisions is something like intuition, is something like empathy, is something like human experience. The best doctors I've ever had are those who you could look at them and say, this is somebody who's gifted. This is somebody who, in a pre-modern world, would likely still be a healer of some kind. This is somebody who's obviously drawn and has a way of looking at somebody else and connecting that to their own experience in useful, fortifying ways. There's an art and a science to medicine that's always been recognized. The pendulum has certainly swung towards the technician, the technical practice. But I think what you describe, and people are wrong to deride this as fluffy stuff. The art of medicine is indeed the only thing that is actually going to make sure that the balance of treatment is positive, that we don't slide into the realm of the treatments being worse than the diseases. It is that instinct. You may not know every possible thing about everything, but there are certainly people in all fields who are gifted in a sense of what might be going on here. And you might not be able to break it down and empirically sort of prove those senses, but that does not mean we should diminish it. We need to have the humility to look at fluffy doctors such as yourself and say, there's something here that we desperately need. And even if we can't codify it or measure it or quantify it, or put it on a chart, that doesn't mean we need to exclude this kind of fluffy thinking from guiding our actions in relation to ourselves or to others. So this is, as one fluffy person to another, Peter, thank you.
Well said. Well said.
No, it's just, I'm just reflecting back what I'm hearing from you, and it's been such a joy talking to you.
It's just great to have a transatlantic conversation.
And I'll be in touch. We're going to do round 2, Peter, and enjoy the rest of your weekend.